Good evening. Welcome to the March 11th, 2024 meeting of the Los Angeles City Health Commission. Can we have a roll call, please?
Yes, Commissioner Avila is absent today. Commissioner Chapa,
Present.
Commissioner Hisarick,
Here.
Commissioner Ho,
Present.
Commissioner Cato is absent today. Commissioner Kalfani, Commissioner Lemus is also absent. Commissioner Mandel,
Present.
Commissioner Osi,
Present.
Commissioner Pack is not here, and Commissioner Shannon is not here. We have a quorum.
Thank you. Can I ask for approval of the minutes of February 2024?
I move.
Is there a second?
Second.
Hisarick, second. Any questions, concerns, discussion of the minutes? Seeing none, all in favor of? Aye. Say aye.
Aye.
Aye. Anybody opposed? Any abstentions?
Abstention.
One abstention. I believe she was not here. So it's 5-1. It's approved. Anybody from the neighborhood council here for comment or public comment? Seeing nobody from the neighborhood council, are there any public comments? Anybody here for public comment? Seeing none, hearing none, we'll move on to agenda item 1, presentation on housing and homelessness, specifically Housing and Homeless Incentive Program, which is a voluntary Medi-Cal managed care plan. And we have several stellar speakers for us. I'd ask you to introduce yourselves, please, for the record, and give some background on yourselves, and then the floor is yours. Thank you for being here.
Good evening. Thank you for having us. I'm Karen.
I'm going to ask you to put the microphone a little closer, so we're actually being televised. I know it's hard to see, but we're being televised on public television.
Okay, is that better?
Beautiful, thank you.
Okay, great. I'm Karen Richmond. Good evening. Thank you for inviting us to be here tonight. I am the Regional Vice President of the Medi-Cal Program for HealthNet, and I oversee the Medi-Cal implementation of enhanced care management, community supports, and investment funding to lift up and build capacity and infrastructure for those programs, also the HIP program. So Los Angeles is my region.
Good evening, Charlie Robinson here. I'm the Senior Director of Community Health at LA Care Health Plan. Oh, is that better? Better, okay. Oh, wow, there we go. And LA Care Health Plan is the local initiative health authority for Los Angeles County. The Community Health Department at LA Care covers all of LA Care's value-based programs focused on vulnerable communities and services in non-traditional settings of care. Within the Community Health Department, we cover behavioral health, social services, all of LA Care's housing programs. I'm joined here today by Carl Calhoun, who's our Director of Housing Initiatives at LA Care. Within our Housing Initiatives program, also we administer the HIP program.
The floor and the slides are yours. We have someone working the slides for you.
Okay.
Okay.
If you can move the slides, just tell them when to slide it, and they'll move it.
Great, thank you. Well, I'm going to kick it off tonight. I understand we have about 20 minutes for the presentation and then 10 minutes for Q&A at the end. Is that correct?
We're very flexible, so if
Okay.
you need more time, take more time.
Okay.
Just move the mic a little closer because we are being taped as well.
Great. We definitely are hoping to have a good conversation tonight, dialogue. I don't know how many of you are familiar with, some of the material that will be presented here tonight, but I'm just going to go through the background and the overview on HIP as though we're talking about it from the ground floor up. HIP, Housing and Homeless Incentive Program, is a voluntary Medi-Cal managed care plan incentive program with The goal of improving health outcomes and access to whole person care services by addressing housing insecurity and instability. So that's a mouthful. The two program goals are help the managed care plans develop the capacity and partnerships to connect their members to needed housing services and reduce and prevent homelessness. So really, the goals of the program are to invest in services to get people housed and keep people housed. DHCS determines the total eligible funds that participating managed care plans can earn. So it is a program of metrics that we will touch upon. The managed care plan submits a initial investment plan that is approved by the state, and from that point forward, we need to demonstrate improvement on certain metrics in order to draw down additional dollars. And we'll go through what those metrics are. Next slide, please. Oh, thank you. So these are some of the metrics that the managed care plans must demonstrate progress towards, and several of them are weighted more heavily than others, but you can see, there are priority area 1, partnership and capacity to support referrals for services. So this gets us connected with the COCs, connected with the CEO, Office of CEO, connected with LAHSA and other organizations, connected with the county in preparation of that initial investment plan. Priority area 2, infrastructure to coordinate and meet member housing needs. This has a lot to do connection with street medicine teams, HMIS systems, and other supports that we have already established, community supports and partnerships with community-based organizations to provide housing navigation, sustaining housing. At the managed care plan, we are also paying deposits for folks that need to have those deposits paid. Priority area 3, delivery of services and member engagement. This really looks at holding folks accountable for increasing members that are screened for homelessness or at risk of homelessness, and ensuring that they were successfully engaged in services that are available to them, including enhanced care management services, which is a new Medi-Cal benefit. It's kind of the highest level of case management that somebody can have, and they really wrap around the individual and create a care plan that looks at all the social supports that an individual might need. Not just getting the person housed, but how do we help them stay housed? Do they have a need for meals? How do we get them from street medicine into a place where they can recuperate, or from a hospital discharge to a place they can recuperate, and then from there get them engaged with housing services that might be available to them. So these are the continuums that this program is expecting the managed care plans to ensure that people actually are engaged in the programs and the support systems that will wrap around and help them to stay housed. You can see on 3.5, we are measured on members who were successfully housed, as well as members who remain successfully housed. And when we think about the HIP program overall, the goal is not only getting a person housed, but to wrap those support services around to keep them housed, up including investments to help them if there are legal aspects that come their way beyond ADL support and clinical support. If there are, landlord issues or things that they need legal support, we are to look at investments around that as well. Next slide. This is a slide just to kind of set up what the landscape looks like in Los Angeles. So we can see DHCS is our Medi-Cal Administrator, and then LA, Kaiser, and HealthNet are the three primary plans. You heard about LA Care being the largest plan. HealthNet is a commercial plan. We are a partner to LA Care, and as of 1/1/2024, Kaiser is also a plan in Los Angeles. SCAN and AIDS Healthcare Foundation are also in partnership with DHCS. Under LA Care, the members will be a part of LA Care, Anthem, our Blue Shield Promise. Those are plan partners of LA Care. HealthNet's plan partner is Molina. So when we're talking about investment strategies, we are looking across the continuum of all of our partners and what makes best sense. The funds actually come into LA Care and HealthNet. Thank you. When we look at HIP versus other CalAIM programs, there are many related programs in the CalAIM. When we hear the words CalAIM, what exactly does that mean? So there are other programs that are a part of CalAIM that are not listed here, but for the purposes of today's discussion, we're really going to focus in on the Housing and Homelessness Incentive Program. But I did mention enhanced care management. I think it is important for us to touch on that because that is really where the intensive case management and the one-on-one with the person that is experiencing homelessness or transitioning from incarceration or transitioning from foster care or a CCS child will receive that one-on-one care support and connection to all the services that are available for them. The community supports are not a benefit. These are optional for the managed care plans to offer. But as we see, the social determinants of health, must be addressed in order to improve an individual's overall quality of life. You cannot have a healthy person when they don't know where their medicine is going to be refrigerated, they don't have a place to live. So the managed care plans are excited about the opportunity to really provide these community supports, some of which I mentioned. But there are others, there are 14, and we are excited that perhaps a 15th might be added. And so looking forward to that. Incentive payment program, much like the HIP program, it has a goal of housing and getting and keeping people housed. The incentive payment program is also a program that provides dollars for enhanced care management and community support organizations to build capacity to serve more people. So building staff with lived experience. Many of the organizations that we are working with have never worked with a managed care plan previously, have done a lot of great work, and have been funded through grants and other avenues. And so this gives them the opportunity to actually have a revenue source from the managed care plan, but also dollars to help them build up the technology they might need, the staffing they might need, etc. And lastly, listed here is PATH, and that is an opportunity from DHCS. They are currently looking at building and the Justice Involved Capacity Act. So they're opening up additional funding from DHCS directly to organizations that are interested in serving the justice involved. Okay. So back to HIP. One-time funding. The Los Angeles managed care plans can earn up to about $400 million. So LA Care, up to about $290 million. HealthNet, up to about $128 million. The basics of the program, the funds must be earned by March 2024. Funds can be spent after March 2024. So to the right, you will see the funding allocation. We were to create and submit a local investment strategy. So worked closely with the COCs, worked closely with the Office of the CEO, worked closely with the county partners and our managed care plan partners to come up with a countywide investment strategy. Submitted that to the state, and then we would earn the initial 5% of the overall budget. From there, we really dove deep into investment pillars and submitted an investment strategy to the state. That earned an additional 10% to get us started with the actual investments. We had a reporting period 1 where we were able and eligible to draw down 35% of the additional dollars. And March is the final reporting period window, ended earlier in the fall, and we will be receiving our notification in March of the additional investment dollars. I think we actually might have received that last week, but looking forward as to how we go about the additional investments. So part of the HIP LA Core Planning team that has been underway has included those participants that you see listed here. LA Care Plan Partners, Anthem Blue Shield, Promise, and Kaiser. Health Net Plan Partners, Molina. And then, so we talked about the Medi-Cal Plan Partners, SCAN, the CEO Homeless, LASA, all the COCs, the county partners, and City of Los Angeles. So we have various forums for participation, stakeholder sessions, planning sessions, technology and data information exchange sessions, and discussion about how we will increase connectivity to community supports, clinical resources. So there's quite a bit of work that is underway. And I know Charles will get into the investment strategies in just a moment. So before we leave here, I think that should cover it from sort of what is HIP. And then I'll turn it over to Charles to talk about how we approached investment priorities.
Karen, thank you. Great overview. I think one thing that I'd also love to acknowledge is we're so grateful that Health Net and the team at Health Net is so collaborative. I think as we're talking about developing services for such a vulnerable community, really important for both of the big health plans in LA County to come up with a coordinated system and coordinated approach. Having two different systems for a community like this one, I think wouldn't work. And so grateful for the opportunity to partner with Health Net on all of this, including the strategy here. If we could go to the next slide, please. One of the things that I know we had hoped to also communicate here in the context of the HIP funding program, and I know Karen mentioned where HIP sits within the broader CalAIM program, but the LA Care and Health Net together have put together what we hope is a really comprehensive program to support operations to get and keep people housed. One thing that may also be worth mentioning here is health plans' involvement in housing services is relatively new. One of the big innovations within the CalAIM program as of about 2 years ago was bringing in housing services under the managed care plan umbrella of services that we deliver. And so a lot of what you see here, especially as it relates to data and infrastructure development, IT infrastructure, community partnerships and capacity building, a lot of that went towards helping to build a network of providers for housing services, a network that operates similarly to the network of providers that provide healthcare services. And so what I mean by that is many many housing providers, and I know that I'm to a certain extent talking to a group that's extremely well educated and well informed, in this world, but the providers historically had worked off of grants. What we've done using HIP funds as well as IPP funds is help to transform that network into a network that can work with a managed care plan, submit claims, get paid for those claims, where health plans can then provide sort of quality and oversight over those providers as well, track progress and things like that. So that's one of the things that you're seeing here as it relates specifically to HIP funding, which I know is the core here. We've made investments basically across three big buckets, all of which are designed to support operations to keep people housed. First one, there's critical access to healthcare and social services. The healthcare piece, of course, is core managed care plan services that we fund, as well as community investment in social services agencies and things like that. The second is community partnerships and capacity building capacity in the community for housing services and street medicine, other clinical services for this community. Again, all with the intent to support operations to get and keep people housed, people being LA Care and HealthNet members. And then finally, as I mentioned, the IT and data infrastructure to support all of these operations, whether it's helping providers submit claims, helping providers share data with the health plan as required by DHCS, also data integration with organizations like LAHSA as well, to make sure that we have as much data as we need and can get on our members experiencing homelessness, so we can more effectively deliver these services. Next slide, please. Oh, do you have something else? Oh, no, I got it, thank you. And so also wanted to take a moment and just sort of walk through in a little more specificity what the teams at HealthNet and LA Care have been working on as it relates to these investments. Again, the infrastructure as it relates to IT, capacity, workforce are huge. They're maybe not the most exciting investments, but I think making investments in the community to make sure that providers that we're asking to take care of our members have the right staff, the staff that's trained in the right way, and then also the IT systems that are required in order to participate was incredibly important for us to get these programs launched. One of the initiatives that we're currently working on and are really excited to be launching in the coming weeks and months is our field medicine program. This fits in that top category of services, clinical services and social services for people experiencing homelessness. And we'll talk a little bit more about that if there's time at the end, because I think that's perhaps one of the pieces that may also be most relevant for this particular group. But that's building off of grant funding that we've been dispersing countywide to date, and so building off of that. And then the two big ones I think we really want to make sure we're bringing to your attention. I know Karen did a great job outlining housing navigation services, housing deposits, and tenancy sustaining services as that core bundle of housing services that health plans are now able to deliver to Medi-Cal beneficiaries. One of the things I think is worth mentioning is the housing crisis in Los Angeles and Los Angeles County isn't coming from a lack of housing navigation. What we've tried to do, and our biggest investment to date has been working with the county CEO's office on a unit acquisition strategy, so supporting master leasing so that our members who are engaged in housing navigation ultimately have more options for units when they have those vouchers. The other piece of that investment with the county is supporting activities of daily living for people who are in shelters and interim housing. Community Supports itself will support similar home modifications for people who have a home, grab bars, things like that, but critically important for us to support people who need services like that and access to living supports like that who are in interim and housed and shelters. Between HealthNet and LA Care, that's a $114 million investment over 5 years. Next slide, please. Going to further specificity here on the specific investments that LA Care and HealthNet both have made. Wanted to walk through not only the list here, but also wanted to illustrate the extent to which the majority of the investments that we're making jointly. Again, just reflecting, I think, the really important component of this to coordinate our services, coordinate our investments for two reasons. One, it helps us scale funding, and two, it helps us coordinate those explicit services for our members. Karen, anything to add here? I know there's a lot of health net on this slide.
Yeah, there's a lot here, but I did want to add that, with the unit acquisition strategy and ADL expansion and some of the other direct-to-person types of investments, they're not limited only to LA Care or HealthNet members. We've invested in opening up these units and these supports across all of the homeless population. So I just wanted to
Yeah, no, thank
underscore that.
Yeah, no, thank you, Karen. I appreciate that. I missed that, and critically important that the HIP investments, again, are for anyone in LA County who are experiencing homelessness, not just LA Care and HealthNet members, though the majority of people experiencing homelessness who are enrolled in Medi-Cal fall under one of our plans. And with that, maybe switch to the next slide, where I think we wanted to take some time and outline the ways in which HIP investments are specifically impacting the city of Los Angeles. As countywide health plans, we have a mandate to disperse funds in an equitable way for all of our members across the county. We know that the city of Los Angeles makes up the largest municipality in the county, obviously, and so really important for us to, I think, one, seek feedback from the city on how we can best serve LA City residents, but also wanted to take an opportunity to walk through how these are specifically impacting LA City residents. As Karen mentioned, our unit acquisition strategy, ADL expansion strategy, many of those new units are in the city of Los Angeles. The legal assistance and eviction prevention also, those are investments that are making through the city as well as the county, both to make sure that the city is fully covered and represented. And then as it relates to field medicine, public health focused, street medicine, encampment support, all of these things also have, we think, a disproportionate impact on the city of Los Angeles given the size and scope of the city. Karen, anything to add there?
I don't think so. I think you covered it.
Okay. And so with that, would love to talk in a little more detail about the field medicine program that we're developing. I think based on some previous conversations with the city and with others, it seems that this may actually be a place of particular interest. I think one thing to mention as we're thinking about sort of field medicine and just generally clinical and social services for people who are experiencing homelessness, we have already made several investments using HIP and IPP funds that support this community. The field medicine program that we're currently launching and have developed we're building off of those investments. And as we took a step back and looked at countywide, what were the big issues? The three things that we identified were a need for primary care, true medical home for people experiencing homelessness. Many of the street medicine models that currently exist and the street medicine as defined by the all plan letter that came from DHCS is focused more on episodic care and sort of more of an urgent care model. The APL all plan letter from DHCS that defines street medicine gave us the opportunity to work with street teams as primary care providers, and that's what we've largely chosen to do, and that's a big focus of our plan. What we're seeking to do in the development of our field medicine program is develop what we're calling a network of field medicine primary care providers, so teams of people who are focused on care for people in the street, care for people in interim housing and sheltered environment, but making sure that those individual providers are able to take primary care assignment for those members. One of the reasons why that's really important is in the context of the way that Medi-Cal broadly is structured. In order to access specialty care and medically necessary services, individuals need to access those services through their assigned primary care provider. And so if you're seeking services on the street from a team that's not your primary care provider, it's sometimes very difficult to access those services. And we're also doing everything in our power to ease that as well, recognizing how important that is. But our main focus with field medicine is to make sure that the right providers who can take primary care assignment are the ones who are also providing services in the street. The other key thing that we heard feedback from providers countywide was lack of coordination across the county. As we all know, LA County is expansive and very varied geographically. The other thing that we're seeking to do in the context of the field medicine program is develop a geographic structure so that providers know or have line of sight into regions that they should be covering, so we're able to expand access countywide, make sure that areas that currently may be overlooked are no longer overlooked. And that's also a place where my hope is as we move forward and as we develop that regional structure, we'll actually be able to work very closely with city council districts, neighborhood councils, and things like that. That'll give us the ability to make sure that those entities are connected to the providers who are serving the community. Right now, to the best of my knowledge, there isn't that type of geographic alignment countywide, and so it's difficult to sometimes align those services. And then the third piece, also relevant here, is we recognize that there was a lack of coordination among city and county programs to serve people experiencing homelessness. I think that largely born from the fact that street medicine for managed care plans is relatively new, housing services for health plans is relatively new, and so we're in the process of creating those linkages with county and municipal agencies. One of the things that we've started to do is coordinate on Inside Safe and Pathway to Home, so we can make sure that people who are in those interim housing locations are connected to LA Care Services and the services under Medi-Cal that they're eligible for. So that's one of the pieces that we're working on there. Next slide, please. So wanted to take a brief moment and just walk you through the extent to which the field medicine and the contributions that we're hoping the field medicine program will make are aligned to our overall strategy. That's one of the things that we will typically do as we're evaluating new programs. We want to make sure that those programs are fully aligned with our broader strategy. We think that the field medicine program hits on many components here. Critical access to healthcare and social services is its core. Community partnerships and capacity building in the context of the field medicine program. We'll also be dedicating HIP funding to build additional street teams so we can get as much more access as we can. And IT data infrastructure development, a key component of any program like this to make sure there's the appropriate data sharing. I know I've been talking a lot about field medicine here. Worth noting, this is a program that we're developing in partnership with Health Net. We're launching the program jointly so specifically if we can think about a street team who's engaging someone experiencing homelessness on the street, that street team has no way of knowing in advance who their health plan is, who their doctor is, and things like that. And so this is a place that in particular, really good example of the reason why coordination with among both plans is really important, because if it was a street team that was only a LA Care street team and found someone in the street who had Health Net, it's really important that they just are able to get the services that they need. So wanted to make sure we were being sort of very explicit about that fact. And then last slide here before I can turn it back over to Karen for some next steps. Wanted to give you a fully illustrative example of how we're thinking about the field medicine deployment. Multiple different provider types are involved here. We wanted to make sure that the program was as accessible as possible for providers, recognizing that given the challenges with access countywide, we wanted to make sure that every provider type had an opportunity to participate with us. We weren't excluding anybody. What that ultimately means is there are a few different provider types that you can see on the map here. And again, this map fully illustrative. I don't know that there are any council districts that are rectangles, but just in case. We're hoping that we're able to find providers who can take responsibility for particular regions. That's important for a couple reasons. One, it helps us scale our capacity building funding, and two, it also helps us with coordination with city council districts, with neighborhood councils, with other programs to know that there are providers in certain regions and to be able to point to those providers. That being said, not every provider is set up to be a regional anchor. Some providers don't have a brick and mortar presence, and some sort of float throughout the county. For that reason, we've created an option for providers to also participate with us as what we're calling floating providers. Two different types of floating providers, one that takes primary care assignment and one that's basically street medicine only. We want to make sure that for those providers that maybe aren't set up to take primary care assignment, that we're still supporting them in the community since their services are still critically important. And then we're also building in very specific support for providers in very high density regions. We're calling that our care collaborative. I guess the most well known and the highest density region is Skid Row. And so we're working with providers on Skid Row on a collaborative model, recognizing that services for people in high-density regions and the structure around high-density regions actually necessarily is different from lower-density regions. So we're working to support that work. Nothing particularly new here. I think we're doing a lot here to learn about how providers are already serving members countywide, and doing what we can to support the work that they've already been doing. And I think that's it for street medicine.
That was a lot.
Yeah. I'm going to take a break now.
You did good. Okay. And absolutely, I think a important point that you mentioned there is, we are learning from the street medicine providers and for those providers that are already doing this work, how we can best support, how we can best lift up the good work that they are already doing, and how we can help to take it to the next level. So I think that's a really important point that you brought up. Okay, how do you stay involved? How to stay involved with HIP? There's a lot of work that's underway, and we talked about the circle of all the organizations that have been at the table or have been at the initial discussions on how we can build an investment strategy, what are the pillars, what are the pain points. So we have ongoing meetings to keep that work going. How to stay involved with HIP, City of LA has been invited, and I believe attended the core stakeholder meetings. Those are still ongoing. And so I believe those invitations are extended, and the meetings are on the books quarterly now, if I'm not mistaken. Attend HIP LA community forums. There are many. Connect on field medicine work underway, some of which Charles described. And then collaboration with existing unit acquisition work with CEO HI. There's a lot of work that they are doing. So I think those are great ways to stay connected with what's underway, and to be able to be a voice of what may be needed in the future. This is just the timeline that we kind of talked about all the way back to June 30th of 2022 was when that first initial LHP plan was due. And then through various measurement periods, we are now really on the wind down. At the end, the final payment is issued in response to our measurement period 2 reporting, which wound down the period October 31st, 2023. So really, we had 2 measurement periods to be able to show and demonstrate getting and keeping people housed and meeting those metrics that we went through initially. And so now we are at the tail end of the ability to draw down all the funds and to continue our investment strategy. Here's our contact information. Carly Goldblatt is a program manager on my team, and she and I work on all of the HIP funding grants. Charles, you've met. Erica Granados is a support manager on Charles' team at LA Care. And again, we're collaborating very closely on most of the investment strategies. Okay. Any questions? Good.
Wonderful. Thank you for excellent and in-depth overview. I really appreciate it, Ms. Richmond and Mr. Robinson. I have a bunch of questions. So clearly, HealthNet is a commercial corporation. LA Care is a not-for-profit, a behemoth that is one of the largest providers in the country. Where is primary funding coming for your whole operation, not just these programs? Is it mostly from Medicaid system, Medi-Cal, or are you getting direct funding from either LA County and or from the federal government?
So the vast majority of our funding comes directly from the Department of Healthcare Services in California. So Medi-Cal funding is the majority of our funding.
Well, vast majority, but do you have some commercial programs also, or is it basically all from DHS?
We have a couple additional lines of business outside of Medi-Cal. We have a dual program for dual eligible members, and we also have an exchange plan.
Okay, and then do you have an idea of what the total fiscal '23 budget for LA Care is?
I'd have to check on that.
Okay, if you can, if you get that information, I appreciate that. And then for HealthNet, your commercial provider, obviously you have PPO insurance as well and other plans. What percentage of, at least for the Southern California region or the region that you're in charge of, Medi-Cal Southwest, I guess, is there a Southwest region that includes non-Medi-Cal?
There is. HealthNet is a statewide organization, and we have several lines of business. Marketplace, which is the exchange products, are offered in numerous counties. We also have Medicare, and that is also expands into dual eligibles. And so those lines of business are up and down the state. They vary. Medicare has certain counties, Medi-Cal has certain counties that separate crossover, and then our group and marketplace exchange products. So we were divided into a north and a south, but most recently, I would say probably when we launched CalAIM, we redesigned the Medi-Cal program because we realized how local we had to go, how in-depth we needed to be at a local level to really understand the coordination and the infrastructure that exists with these community-based organizations, the COCs, the school districts, et cetera. So we have a more regionalized approach on the Medi-Cal program versus a Southwest and a Northwest.
And the same kind of question is, what percentage of the overall book of business is Medi-Cal as opposed to Medicare or other commercial insurance?
So our largest book of business is the Medi-Cal program, but I can definitely get you the breakdown on the others.
That'd be important, thank you. And also, in following up in that, managed care in general goes up to the Department of Health Services. The insurance commissioner handles other issues. So none of your programs have oversight by the insurance commissioner, am I correct? Or are there some programs that are?
I need to check on that.
Okay.
I'm not exactly sure.
So are you talking about DMHC, DHCS, like the regulatory agencies
Yes.
that govern certain programs, and then CMS governs the Medicare. DMHC would govern the commercial and marketplace exchange products, and then DHCS is the governance on Medi-Cal.
Okay, so if you look at Medicaid programs nationwide, fee-for-service Medicaid, California is one of the poorest payers of the 51 Medicaid programs in the country. The last time I checked, we were number 49. Alabama pays better. Is that the same thing in the capitated programs, or are you guys being paid on par with other areas in the country?
So there's a sort of complex formula for
Complex
formula for our own capitated rates. But the capitated rates that we get from DHCS, I believe, are in line with the California Medi-Cal fee schedule,
Which is pretty poor in comparison to other states in the union.
correct?
Is there any movement from your programs or to advocate Sacramento to improve it, because there's a provider shortage and there's difficulty getting access to subspecialists, et cetera, in both your plans, which you've been criticized for in the press and also by the government itself has fined you both for delays of getting care. But it seems like they fine you, but they don't give you enough money to pay to provide the services. So you're kind of in a catch-22 because you don't have the total funds to get the providers in the first place. So is there any way that you see a way of getting around that catch-22?
I think we're looking at HealthNet in all ways to address the provider shortage question overall. Reimbursement strategy being one aspect of it. The fact that there are not enough specialists in certain specialty types is, a sort of a different bucket to take a look at what would actually interest folks about, taking on serving that population, to your point, at a certain fee schedule, but not only that, that is one piece of it, but there's also, the education aspect and just, there's a lot of other aspects about building like a workforce under a certain specialty type, notwithstanding reimbursement. So what we're trying to take a look at is how we can create and relieve some of the impact on the specialty types through new provider types and workforce that is out there and available. So we're looking into doulas and how our hospital partners are impacted with their OB, the maternity wards and having available OBs. And so looking at alternative provider types that can help to relieve some of the load on our impacted specialists. OB is one that we are very focused on, but there have to be creative strategies beyond just reimbursement for us to really help to relieve some of that access issue.
Yeah. And I'll say, just to add from the LA Care perspective, while most of the network issues that you've highlighted certainly fall outside of my scope, as it relates to specifically community health related issues, community health department related issues within LA Care, field and street medicine in particular, the issue that you've highlighted translates there as well for a couple of different reasons. One, the Medi-Cal fee schedule doesn't always cover costs for providers, even providers in a brick and mortar setting who are able to schedule multiple visits a day. We find that is actually exacerbated by the low volume of a street team, where if you don't have an office and you're not scheduling people back to back, the provider groups have a lot more downtime as they're looking for patients or they're out in the field. One of the ways that we collectively have chosen to address that issue specifically is through the use of HIP funds for capacity building, where we're funding additional teams through that funding so that those teams are less dependent on the rates that we're able to pay through the Medi-Cal program. So that's one way that we're trying to fill in the gaps where the rates don't necessarily match the overall cost for the providers. There are additional incentives that we're building into the program as it relates to specialty care, primarily as it relates to that primary care assignment. We want to make sure that providers are similarly incentivized to take members in under assignment and are also providing incentives for them to do so, recognizing that coordinating that care and getting them access to those specialists, especially for providers that are at risk for those services, can be quite expensive. So in sort of the more narrow world that where I operate, we certainly see those same pressures, and we're utilizing some of these incentive funds to fill the gaps.
This shortage of physicians themselves, as opposed to physician extenders, are both primary care as well as the subspecialists that we just talked about. What would you say are the 3 or 4, at least in LA City, if you know it, or LA County, if you don't, are the 3 or 4 major reasons we're having a provider shortage and difficulty getting providers to work with your plans?
That's a question I'd actually be more comfortable deferring to our network development team. The team at LA Care that manages our network, manages our specialty networks as well as our primary care networks, deals with multiple different provider types. So LA Care has many delegated providers where the providers themselves manage their network, manage their specialty network and their primary care networks. LA Care also manages its own direct network. But I'd be happy to put you in touch with the teams that manage those networks. I think they'll probably be able to get you a more detailed answer on some of those challenges than I'll be able to provide.
Yeah, if you can get that information, if you can just have that sent directly to us or to our research
Sure,
associates.
yeah,
you
that's,
know, this way we can get the information so we could report
Yep.
to the city council better
Yep.
with more accurate data, because clearly there's a shortage in LA City of both primary care doctors as well as,
Yep.
and as long as you're asking your resource people, a specific question that I would ask within that is an issue of either board certification or maintenance of certification, MOC, adding to the problem. We know in LA City, there's a problem that there are some groups of cardiologists that have been board certified, but have not maintained their certification with the American Board of Medical Specialties, though they're certified elsewhere. But there's a catch-22, and the contracting doesn't allow them to work for LA County directly.
got it.
And so there's a shortage of cardiologists. There are cardiologists in LA City who want to work, but LA County can't hire them because they're not maintaining a certification that has never been proven to improve quality, which is part of their issue. And plus it's costly and takes them away from other work. So they're willing to work for the city for the amount of money that the city or the county will pay them, but they're not willing to be hired by the county because they don't maintain a ABMS certified MOC. Total tangent to our conversation, but goes to a point of there are doctors who want to work that can't work. And then you talked about the funding, the $400 million and the way it broke down. Was that extra funding that came from the state, or was it carved out of the money that you normally would get from capitation?
The HIP funds were extra outside of the capitation.
And do you know where that originated from, the $400 million?
I believe I want to say it was budgeted,
it
and
was.
there was federal and state matching.
Yep, and Carlos.
And if you can repeat that on the record.
Yeah,
on
there's
the-
a American Rescue Plan Act funding, so left over from COVID.
So the federal government gave the money because of COVID. It was matched partially by the state, and we were able to creatively find better programs or create better programs that potentially can get health care to people in the streets, therefore are saving money for the system in general, basically in a
Yep.
nutshell.
Yeah, I believe so.
Okay, so that was one-time funding because of COVID, but so we can't guarantee that there'll be other funding, so it has to be, it has to prove cost savings, otherwise there won't be money for the program in the future,
Correct.
correct?
Yeah, the sustainability question is one that we get on a regular basis, and one that also we think about on a regular basis with all of our investments and all of our community supports that we deploy.
Excellent, thank you very much. Commissioner Hissery.
Thank you. Thank you for your presentation. Could you describe for me just a little bit the distinction between field medicine and street medicine? I'm fairly familiar with what street medicine is. We see it publicized quite a bit, but I'm not sure what field medicine or what the distinction is. And then unmentioned, but does emergency medicine fit into that spectrum?
Sure. Yeah, no, it's a great question. The key distinction between field medicine and street medicine is included within field medicine. So it's a key component of field medicine. What field medicine includes that street medicine doesn't is, on the one hand, care in a sheltered environment. So in a shelter, in interim housing, street medicine doesn't include services that are provided to people who are experiencing sheltered homelessness, only unsheltered. And so that was one of the things that explicitly we wanted to include in our program, so that people who were transitioning from the street, from an unsheltered environment into a sheltered environment, interim housing or homeless shelter, could still access care from those services, and we could include that in the broader program. And then within field medicine as well, one of the things that we are creating as a distinction between our field medicine providers and street medicine providers relates to primary care assignment. So in our program, if you're a provider that's street medicine only, the distinction there is you're not taking primary care assignment, and there are a lot of reasons why providers might not want to, and we certainly don't want to exclude those providers. But in our context, field medicine specifically refers to providers who are taking primary care assignment, who are making a commitment to provide the full suite of primary care services to people who are experiencing homelessness in the street, in shelters, and in interim housing.
Is the care in field medicine, is the care rendered on site where the patient is, or taken to a facility?
Both. So in the construct of field medicine, we want to make sure that we're continuing to focus on street-based services, but also making sure that people who are receiving those services have access to higher level of care when they need it. Which gets to I think your second question about emergency room. We're hoping that this will reduce the need for people to go to the emergency room if they can access primary care from a field-based provider who can then bring them into a brick-and-mortar facility if they need to.
And I assume that mental health is covered under this, although I don't see it mentioned specifically, but mental health issues. And will Proposition 1, should it end up passing, affect your program in some way?
We hope there's a positive effect. I'm certainly not an expert on Proposition 1.
It's
but
complicated.
It's very complicated, indeed.
Yeah.
It's quite complicated. I don't think that there are any sort of explicit impacts to the program that would require us to sort of change the operational construct of the program, but we're certainly hopeful that the proposition does have a positive impact.
Yeah, because it hinges on homelessness and health. I mean,
Yeah.
it's kind of right at the
Yeah.
juncture of what you're dealing with. Thank you.
Dr. Kalfani?
Thank you. I have a couple of questions. One, you talked about you have to demonstrate progress to draw down funds. So is there a report or something that demonstrated progress that can be seen or reviewed?
Absolutely. So we had 2 measurement periods, and that information was, I think, on the slide. I got my slides out of order. I'm sorry. Here we go. On the timeline slide, did show the measurement period, measured results. Measured metrics that we talked about May 1st, 2022 through December 31, 2022, so a measurement period of 8 months. And a lot of that was making sure that we had the commitments in place and the counting of individuals. And then measurement 2 was January 1, 2023 through October 31st, 2023, 10 months, to show a marked improvement in the individuals that were reported during measurement period 1, for example. And so those are the 2 windows of measurement. Those reports were submitted to DHCS. Now, I am not positive if they're posted, however. I know our IPP summaries are, but on the DHCS website, I believe it's available because all of our LHP submission and the rest of our letter of intent, all of our investment plan is available publicly. So I would imagine, I just don't know for sure that it is.
I'm not sure that
Yeah,
we'd
yeah.
have to check. It's also possible that it hasn't been made public yet.
Okay.
Right.
Just curious, just realizing there's been lots of investments. We know lots of things have happened. We don't always see that the needle has been moved anywhere with all of these investments. So I'm always very curious about like what's been demonstrated and what's been seen. Also just curious, you mentioned a little bit about work in high density areas, mentioned Skid Row as an example. Work is, when you think about there's efforts already in some areas. So like what's being done to make sure you're not, there's not duplicated efforts, right? Because other folks are there doing work. So what's the communication, the link, what's being done to make sure we're not duplicating efforts when you think about so much that's already been done or what's being done?
Right.
Or, what's falling between the cracks? What are you all doing in those areas?
So if I understand the question correctly, it's a question related to care, sort of coordination of care among multiple providers, both in high-density and low-density regions. The couple things that we're doing in low-density regions outside of areas like Skid Row and things like that is developing that regional structure so that at least providers know who's in which region and they can sort of help coordinate that way. I think we also are trying to create a system that's actually relatively dynamic, recognizing that individuals may be moving, they may want to keep their same provider, so we don't want to create any barriers there. The intent behind that regional structure in some of those lower density regions was just to make sure that we knew, everyone else knew, and knows sort of who is where for that very reason. And this question is exactly the reason why why we needed a different plan for Skid Row and other areas that are high density because there are many providers there. And the three core providers on Skid Row, LA County Department of Health Services, JWCH, and LA Christian Health Centers, have been there for decades, and so they are experts. They're fully committed to that region, and they are already in many ways coordinating with one another. Our intent was to help support that coordination, augment and improve the coordination that already exists among the providers that are there, recognizing that that was needed, to your point, to make sure that we weren't creating a scenario where we were perhaps bringing more providers in, creating sort of more coordination issues versus working with the providers that are already there, helping them build capacity and helping them coordinate.
And I think you starting to answer my last question.
Okay.
As it relates to using or partnering with existing providers. So someone had come from FQHCs, and I hadn't heard anything about FQHCs or other community partners. So you all are really using the capacity of providers like FQHCs or community health centers in these areas in terms of care. Okay.
Correct. Yeah, and we just completed collecting letters of intent to participate in the program. We have, I think, 17 letters of intent that we collected. Many of them are FQHCs and other providers. One of the things that to your point exactly, that we've all been really focused on is recognizing that because there really is a critical access issue, we wanted to make sure that we were bringing in as many providers as we can. I think that's also why you see multiple different sort of provider types, trying to acknowledge that certain providers just operate differently, and so we wanted to accommodate that.
Right. And that may be the vehicle or resource for some of the street medicine work, like you said, for some of the services, if you don't have a primary provider or regular source of care, you don't have access to specialty care. But some of them are doing some street medicine now, so that could be a way for some of those units to make sure those patients may have access to some of those services. It's just a
Totally,
one way.
you're totally onto us. That was basically as we were doing research, that was basically the premise of the program. We realized a lot of these providers who are already primary care providers in our network are also fielding street teams, and so our intent was to help them do more of that.
The City Council has passed a motion for the Health Commission to make a recommendation on possible programs, whether there have been created or need to be implemented, on how these HIP dollars that we have on the table currently could be used for people experiencing homelessness in Los Angeles. So I have two questions. So my first question is, are there currently programs that apply to the City of Los Angeles that are funded by the HIP dollars?
Definitely. There are organizations that we have funded with very specific programs, and I know they have other programs, and we do have that information available, and we do talk about that at our stakeholder sessions, and everybody has visibility to what those investments are. We've highlighted some of them here, but we can definitely go deeper with you in what those programs and investments are. Like, for example, we invested in the Mayor's Fund, right? Underneath that, there are many layers of supports and services that are available for individuals, but really when we think about it, it's about getting, helping them navigate any type of renter, landlord challenges that, so under that, there's a big umbrella, right? So we can talk about, what that looks like at a program level under those investments, if that's helpful, and get you that information. And then again, plugging into the stakeholder sessions, we have very focused ones with different, some include managed care plans, some we open up broadly to other stakeholders, some are more limited to the managed care plans and the county and LAHSA, the COCs, where we're talking more about what, programs and investments still need to be made. So I think that there's ample opportunity to plug in there, and we can definitely dive deep on that.
And one brief thing to add as well. I know one of the things that we've talked quite a bit about, and one of the things I know we're actually quite excited about, especially to be here and to be speaking with you, is all of our investments are countywide investments, and so all of them, I think, should impact the city of Los Angeles disproportionately given the city's size. One of the things that I think we're excited about and recognize is the city itself has an extraordinary infrastructure through neighborhood councils, through the city council, through a lot of different mechanisms to engage with communities and to help us understand where the need is. And so I think one of the things that comes to mind for me, and I know since I don't want to speak for Karen, but I know we've talked about this certainly, as our programs are maturing, even the programs outside of HIP explicitly, those having housing navigation, housing deposits, tenancy sustaining services, our ECM program, all of these things are places where we are actively trying to increase enrollment and increase engagement in the community. And so I think there is a really exciting opportunity for us to continue engaging with the city on those programs, either that already exist or investments that have already been made. And I know go forward, we still are. I think we're still working with the state on sort of explicit and exact funding amounts, and we're working on our own planning around how to disperse those funds in the future. I think doing so in collaboration and in partnership with city and other municipalities would be really helpful for us, certainly, because from where we're sitting, there's no way for us to know where the need is and what the actual what the situation is in certain parts of the city without input.
Thank you. So obviously, I'm looking at the date here, March 2024, and we are in March. It says here that the funds could be dispersed after March, but that the program should be submitted before then. So in terms of us, this commission, making recommendation or any kind of recommendation to the MCPs or to the city council, I guess what I'm asking is it too late for us to even explore possibilities to get a hold of these HIP dollars, because it would be a shame to lose them? Well, we won't really lose them. They will still be dispersed to the city of Los Angeles, but I think in reading the documents, I think the city sort of wanted to have direct access to these funds while they're available, if that makes sense.
Well, what I would say is that, again, what we talked about, the investment priorities and the progress, when we talk about, what we were looking at, there are many opportunities here. Unit acquisition strategy. So we have our pillars, right? We have HIE, data exchange, and workforce, pretty broad bucket there. Field medicine, we discussed. There could be creative opportunities to engage there. Programs to get and keep people housed, right? Again, this is, HIP is focused around permanent and supportive housing, right? So what programs are we already embarking upon? Eviction prevention, capacity building for enhanced care management and community support, unit acquisition, falling under ADLs, right? ADL support. But again, permanent supportive housing, our unit acquisition strategy, and then the last pillar being ADL support. So the way I'm thinking about it is those are pretty broad buckets, right? And certainly there are probably a lot of programs that we are funding already that maybe, I don't know if you have visibility to all of them, but I think it would be worth looking at. And if there's something that you want to share with us under these pillars, which again, I feel like they're very broad, right? With the goal of getting and keeping people housed. We definitely have the forums to discuss what those look like. I can tell you that yes, you know, we have committed to investments that are already, those commitments are already made, some of which we talked about. But there are still local investments that fall under these pillars that we are discussing today. I'll let Karen, do you?
No, I agree. I think perhaps the way that I would think about it is for the investments that have already been made. I think thinking about ways to optimize those investments and those services in the city of Los Angeles is a place that we would be delighted to partner. And I think go forward, if there are specific projects and things like that that we can take in and evaluate, I think we would also be grateful for that type of input. I don't know if that's exactly the answer to your question, but.
Yes, you did. You provided clarity. Thank you. And last comment, if I may, Mr. President, is that I think today's discussion is a perfect opportunity to say that this conversation is a non-stop conversation. I would like to see the Commission to explore further the possibilities, even outside the $8 dollars conversation that we're having to do on how we can explore more possibilities to formulate recommendation either to the City Council or looking back into the annual report that the Commission has published in the past and delve. In other words, what I'm saying is let's delve deeper, in one word.
I think we have consensus on that. I don't think we have to, it's not debatable. I think we would all agree with you on that. I don't think that'll be a problem. Dr.
Thank you.
Osi.
In reference to slide 8, the core planning team, I'm just interested to know if there were any community members currently experiencing homelessness or former folks experiencing homelessness that were on that core planning team
That's a great question.
to lend a community voice. Do you know?
Is your question if we had individuals experiencing homelessness come to speak with us before we made investment strategy?
Well, are they a part of the planning team?
Are
If
they
you-
part of the planning
Yes.
team?
I see a lot of organizations, however, I don't know if any of those organizations are specifically representing an individual in the community experiencing homelessness that can really speak to maybe some strategies that you all might want to consider.
I would say where we have met with the community is through a couple of avenues. One, the community-based organizations that are doing the work today, right, that are on the ground with the individuals. The other is through our CACs, which are community advisory committees that we have at each managed care plan, where we are socializing each body of work and obtaining feedback from the community on those investment strategies or those clinical programs or whatever topics that, you know, we want advice from the community on. And there is community advisory committees that we have regionally, so it's very locally focused, even though we are a statewide plan. So we have local community advisory committees only for Los Angeles, only for San Diego, only for the Inland Empire, et cetera. So we can make sure that we are touching the members that are experiencing whatever we want to get feedback on. So I think those are the two touch points that come to my mind. Is there anything that you would add there?
No, I'm actually quite grateful for the question. I think the honest answer is that I don't have a sort of very, very clear answer for you. Means that I have a really important piece of feedback to take back to my team, and something I think that's really important for us to think about. So I really appreciate the question. And I think the one place where I know we do get direct input from members of the community, maybe not direct, but many of the CBOs that we work with who bring proposals to us are bringing those proposals that are informed by people from the community. So I know that's one step removed from what you're asking about, but that's definitely present in certainly those proposals. And so I think if we look at the people on the core planning team or the organizations on the core planning team, they themselves are receiving input from the community. But the question was, I think, an important one for us to hear. So I appreciate that.
Thank you. And my last question is in reference to the provider types that are being utilized in addition to physicians.
Sorry, can you repeat that?
Provider types that you all are utilizing in addition to physicians.
Provider types in the space of getting people housed and keeping people housed, or just in general?
Providing care.
Providing care, okay. So alternative provider types that are now an additional source of revenue for these community-based organizations, as I mentioned, is doula, for example, also community health worker. They are not necessarily, I mean, I'm calling them a reimbursable service provider. So what I'm seeing is that the DHCS is approving alternative support mechanisms for our providers. So community health workers are now reimbursable. So they have another source of revenue and the ability to have those folks support some of the work that typically impacts the office, the provider's office, or the hospital, right? They are able to employ community health workers and to actually get reimbursement from the managed care plan for their services. The same with doulas. So that's really been an exciting new source of revenue. We've been out speaking with our hospital partners and some of the patient navigators that they've had in the impacted ERs are no longer funded, and so they were very excited to hear that they can employ community health workers to talk to people about alternative sources of care besides the ER and get reimbursed for their services.
I think the promotoras are involved in that too.
Right. How about nurse practitioners? Is there, yes?
Definitely midwives, nurse practitioners.
Yeah, I'd say the street teams themselves actually have quite a varied composition across different provider types. Some street teams themselves include a physician, some do not. Many heavily utilized nurse practitioners, physician assistants, other what I think we're calling extenders, but I don't love that. I don't love that terminology. And then also social workers and others in the street as well. I think one of the things that we're finding is as Medi-Cal is expanding into some of these sort of non-standard services, we're also now working with non-standard provider types, which is really exciting. But I think that what we're seeing is actually quite a varied group of caregivers and other providers that are now serving our members.
Thank you.
Going back to community input, Public Health Act 330 mandates that all the federally qualified health centers have to have community input. So depending on how many of your providers fall into that category, it's pretty large,
Yep.
percentage of your population or the providers. So they're required to do that on a monthly basis. And also their boards of directors have to be 50% 50% plus one person. So it's not 51% necessarily, but it could be 55% or whatever, depending how many board members they have. But it's 50% plus one, so it could be one more than a majority, have to be a community member, which could theoretically, if it was a clinic that was seeing mostly homeless people, homeless or unhoused, so it meets that criteria as well.
And pardon me, was that federally qualified health centers that you said?
Public Health Act 330, which is reinforced in the ACA as well.
Okay.
Commissioner Ho.
Thank you. One more question that just popped up in my mind. Earlier, you mentioned the role of neighborhood councils. Could you clarify a little bit what, in this space of work, what would be the role of the neighborhood councils, or how you intend to partner with the neighborhood councils?
So that's actually, I might answer your question with a question. I think, I don't know that we have an explicit operational plan to do that. I think our priority at this point is launching the field medicine program and making sure that we're sort of building that map. I think we would love feedback from you and others on the best way to engage with neighborhood councils and basically make sure that that's a conduit to get us feedback on issues, us feedback on providers and need and things like that in the community. So I think in my mind that's a great source of feedback for us and certainly a great piece of feedback for providers and a way to connect providers to the community who, you know, if you're not in the community block to block, you might not know exactly what those blocks are like and who's there. So I think that's one thing that I had thought of, but I'm certainly not the expert, and so welcome feedback on what that should and could look like.
Dr. Chapa.
So data can be incredibly powerful, right? A right data set can highlight efficiencies, highlight gaps, and make really strong cases for successes, improvements in programs. So I see in your, the presentation, you have a lot of data sharing initiatives, but do you guys have a thoughtful approach to your data collection strategy? So I think, the data set's only as powerful as what you put in there. And so you're going to have dozens, if not hundreds, of data points you come across in every effort and opportunity you have. And it'll be a bummer 1 to 5 years from now to realize you could have been collecting a certain metric that would help you make some powerful case for something that you'd missed out on collecting.
Yep. You're hitting the nail on the head. LA Care's data infrastructure is complex, to say the least. We have, to your point, multiple different types of data, even outside of the community health department, outside of services that we're delivering to our members experiencing homelessness, whether they're claims coming directly from our direct network, encounters coming from our delegated network of providers, touch points in the call center, touch points with care management. There's a huge amount of data. Recently, we also now have data coming from LAHSA, which is incredibly helpful that we're able to match with LA Care members. That was directly as a result of an HIP investment. And that's data that we're now, it's relatively new, that was actually up and running. It took some time. But that's data that we're only now learning how to use and coming up with really powerful use cases for how to identify members who are in different places to connect them with services. And so it's an ongoing process, but we certainly have, there's a lot of opportunity and a lot of runway for us. And I think given the time to launch a lot of these things, we're only now really just getting started with those use cases. But I certainly don't want to speak for Health Net. They have a whole different complicated data infrastructure.
We have a lot of the same opportunities in that we have, a delegated environment. So we are working, with receiving data from some of the larger organizations that we work with. But in addition, the COCs and just even the HMIS systems for homeless services are not on the same platforms. So, and looking at, how can we make investments to move maybe, for example, a particular COC in Long Beach so that they're on the same instance as LAHSA, right? So at least they're all able to see kind of the same information and exchange information, then we can have a similar platform to be able to pull information. Those are the types of investments that we're looking at initially to, help to support what is, what may be, I don't want to say broken, but maybe fragmented, and that exists out there already. And so how can we at least get everybody on the same platform, so now we can talk about how we can exchange data in a more meaningful way? And then the county organizations, investments in enhancements there, investments in lanes as a health information exchange. So we also did a study, LA Care, HealthNet, and the managed care plans, pulled together various stakeholders to do a data analysis, I guess, if you will, looking at, where we could make countywide investments in data and infrastructure, if at all, that would actually help us to be able to improve the way that we all communicate. And so that was a year-long study, really looked at the top EHR systems, electronic health records that are being used by providers that are out there. Do they even connect to a health information exchange? What are those health information exchanges that are out there and in use? What is the state's viewpoint? Because they also have a data exchange framework that they are mandating. So how does that intersect with kind of what we're doing at a local level? And so we have some of those recommendations and strategies for investment, which really come back to, one more time, the connectivity with HMIS, the connectivity with lanes. Are the hospitals connected with lanes? So therefore, we know who's being discharged. Are the community-based organizations connected with lanes, so that way the hospitals know they have an ECM provider? They need food. They need, they're homeless. How to get them connected with short-term post-hospitalization, because they are homeless, so they're not just returned back to the street after they have surgery, right? For example, we hear about these things. So information, absolutely. Data, it's just absolutely essential for us all to have that at our fingertips. It's how we get there is kind of the quagmire that we're sorting through. But we think we have some good investments that have really moved the needle, but would, if there are others, we would love to hear about it.
Yeah, that's great, thank you. I really appreciate that you kind of went into what my next question would have been, which is there an effort to standardize the data? Because it seems like data sets never talk to each other well, because everybody's doing it in their own way, and it sounds like you guys are already ahead of that, so that's great.
Any other commissioners? No,
Commission President, can I just have a clarification?
please.
When you mentioned the core stakeholder meeting, are the core stakeholders the same folks who are part of the core planning team, or is that a different group?
So there are, so the answer is yes. The LA Core Planning Team and the stakeholder sessions that we host, there are probably subsets of that. So I would say, so for example, on the field medicine, Charles and I and our clinical folks at the managed care plans are talking through, let's say, some of the barriers in street medicine, some of the obstacles, and what we can do to address it. So then from there, we're going out to a larger stakeholder session and getting feedback. Okay, so there are different types of meetings that include different stakeholders. So then we're meeting with the county. This is what we've heard, county partners. what do you think? Are these the barriers that you're aware of? And obtaining feedback, and then we're going back and meeting and having discussions on putting together a framework, and then we're taking that back out to socialize that with a group of stakeholders. So there are ongoing meetings that are more about sharing information about where we're at with the project, updates to work that they've already been involved in, and then there are, you know, the smaller work groups that are actually working through that and then taking back the messaging to the larger stakeholders. So I think there's a variety of different types of sessions as we went through even formulating a plan of what would be needed for homelessness and tackling that. The data work group, I think I mentioned. So I think there are a variety of different forums. I'm sorry, I'm not trying to be vague.
It's okay. I
Anything
just
you would
wanted to be,
Nothing for me either. I talk to Karen all the time.
Yeah.
so just wanted some clarity on this. And then just, the commission actually had a really great discussion last month with the health workers and promoters who work with the community-based health organizations, who would probably be a good source of folks to use if you're going to be doing any community outreach. But I think that a lot of the commissioners here who are doing work in the community and in the health field may also have some input on who are good folks who can actually go out and get the word out.
Thank you.
I'd also suggest that the health deputies of all the 15 members of the city council, at least in the city of Los Angeles, would be potentially great people to get input from, because they're hearing directly from their direct communities as well. It's another possibility for you to just email or call people and get input for as well to improve the program. Commissioner Ho.
Thank you. Last question. How do we find out about the details about the core stakeholder meetings?
So I think, I want to say that they moved it to quarterly at this point.
Correct, and
Yeah.
and there are representatives from the city who are already attending.
Yes.
Is it open to the public? When it says stakeholders, I'm assuming, but
Again, if we're looking at, you know, the core planning team and the various stakeholders, those that are at the table on the quarterly meetings are not publicly open.
But as a commissioner, you could speak to the LA representative directly and get feedback from them and or give them input if you want to as a commissioner. Yes. Any other questions? Seeing none, thank you very much, Ms. Robinson and Ms. Richmond. Really appreciate. What? Yeah. We really appreciate your coming down here to City Hall and testifying to us and educating us and enlightening us. We're truly appreciative of your knowledge and education, as well as everything you're doing to help this population of underserved individuals, and we really appreciate those efforts. We have other city business to do. You're welcome to stay, but we won't take it personal if you want to leave. We would like some response to some of those questions we asked. If you can send it to us. You always can give us input directly through the city clerk or directly through our research associates, and vice versa. If you don't mind, we might reach out to you to get more input when things come up in future meetings. But thank you very much for your time and efforts. Thank you as well for your associates who've come down here with you. We really appreciate all your efforts. It's a wonderful presentation. Thank you.
Thanks so much.
Thank you.
Moving on to agenda number 2 is our report. Do you want to come to the table, or? Monica?
floor is yours.
All right, amazing. Good evening, everyone. Thank you so much for having me.
Monica, just put the microphone closer.
Okay,
There
is this
you
better?
go.
All right, amazing. So we've sent out our report, and I hope that all of you guys had a chance to look over it. And we have been, looking over your feedback and a lot of the changes that have been suggested via email as well. And as of right now, we've updated as much as we could, and we've made a lot of adjustments according to the feedback that was given to us. We just want to make sure that everyone did have a chance, and if there was any feedback that could not be communicated, over email or through suggestions, that we would love to hear you guys express that as well. And another thing, if you guys have any updated profiles or headshots, please send that to us so we can update it accordingly.
How soon do you need that?
Sorry?
How soon do you need that?
Yesterday?
In the next few days, I assume.
I'm sorry, I didn't hear that.
In the next few days, you need it?
Oh, yes, please, yes.
Okay.
Yeah.
And I was just trying to remember, did I send updated bio information?
Let me check.
What I would suggest,
And if not, I can resend it.
what I would suggest, if you don't mind, is if you can, either you or the city clerk send the current bio as it's going to go into the report and photograph to each of the commissioners,
Okay.
so they can just sign off on it before it gets set in stone.
That will be helpful.
And the other thing is, my assumption is that everybody has given input on the entire report. For the commission to discuss today is, do you want to publicly go through paragraph by paragraph like we've done in previous years, or are you more comfortable being that everybody's already given their input and there was no areas that were of controversy or difficulty to vote on it today to be approved? It's up for the commission to discuss now. Any input?
I like the report. Great job. I'm ready to approve it. I like the report. Great job. I'm ready to approve it if others would like to.
Would you like to make a motion?
Commissioner, can I just add one thing?
Yes, please.
I know that the folks from the planning department provided some input on the section involving the Plan for a Healthy LA and their presentation here, which was forwarded to the research associates. I don't know if that was already incorporated.
I'm looking over it. I reached out to Marvin and Claire earlier today, and they said that they were all good to go. I know that that was in my section, but I can double check with them.
So they sent, the Commissioner Cato asked them to review what was in the report, and they submitted some comments back to Commissioner Cato and myself, and I forwarded it to the research associates.
Okay. And Commissioner Cato reviewed that and agreed with it, I thought.
I am assuming so, but
Okay. So, if you'd like to make a motion to approve the report with 3 things that we'll double check, is one is the accuracy of everybody's bio and most update photograph. 2 is this one section on the planning that Commissioner Cato, who unfortunately, because of a family emergency, could not be here today. So we could just double check that he reviewed it and is comfortable with the way it's written. I am, but we can approve it with that one second modification. And then the third modification is everybody really comfortable with the conclusions or the summary, the executive summary as it's written, or do you want more time to review that? And we could, can you, Monica, can you show the executive summary to us today, or is that
Is that
Yes.
linked to the slides or not?
It should have been sent to the email. I believe it's all there. I'm looking for it right now.
I know it's in the email. The question is, can we see it all today on the big screen or not?
Could I let me see?
Can I put it on here?
Okay. I have an adapter. I have an adapter. Okay.
Okay. Yes, that's what I thought. Okay, I just wanted to make sure, The city attorney was just clarifying what I thought, which is the public has to be able to see our draft and have public comment on it before we vote and approve it. Having said that, what you're going to be, or hopefully what you're going to make a motion on, if we get a second, is to approve the draft as is with those 3 modifications, so that could be made public, at least, is it 3 days? 72 hours, or is it 2 weeks? 72 hours before our next meeting, and then we can approve it for publication and submission to the city council at the next meeting. That's what we'll hopefully be doing, if she can get up.
Understood.
Next month.
Because while they're doing that, I think you can make that
Okay.
motion,
All right.
and if we get a second, we can then have debate on the motion on the floor, and we can call for a vote on it.
Understood. So I do move with the aforementioned caveats to approve the draft for public review.
Is there a second?
I second.
Is there any discussion on the motion on the floor? No. Then,
That was easy.
with the hope that it'll be, it's going to be up there in a second. Excellent. Almost. Can we get a vote? Can we get a vote on that draft, please?
Yes, Commissioner Avila is absent. Commissioner Chapa,
Yes?
Commissioner Historick,
Yes.
Commissioner Ho,
Aye.
Commissioner Cato is absent. Commissioner Kalfani,
Yes.
Commissioner Lemus is absent. Commissioner Mandel,
Yes?
Commissioner Osi,
Yes.
Commissioner Pack is absent, and Commissioner Shannon is absent. That's,
It's approved.
motion
Okay,
carries.
good. So hopefully we can see the, if not, we'll have to do it the old school way, which is we'll all go on our phones and look at the email.
Yep.
Oh, well, when Monica's doing that, I'll just publicly thank all our research associates for their unbelievably hard work and dedication as volunteers to create this amazing report, for doing the background reviews, research, getting support for it, and the data as well as the references, all in supporting each of the chapters, and want to publicly thank all 4 of them for that.
Yeah, it's nicely done.
Yeah.
Regarding past reports, were there bound copies printed of the reports? And if so, are any of the older reports still available in print?
They're all available online.
Not
and-
bounded though,
and-
correct?
And they've never been bound per se. They have been printed in color copies.
Okay.
And the city clerk might have those. We can ask when she's done with
Okay.
what
I
she's
don't
doing
know why
now.
I thought it was bound at one point, at least 1 year, but maybe not.
The last year has not been printed yet.
Okay.
Commissioner Shannon supposedly got a grant to have those printed. I don't believe they've been printed. One would argue that if we get this approved in 4 weeks from now, then maybe it'd be better for her to have these hard copy printed. I believe the grant that she got was for $10,000. That might be enough to print last year's and this year's. Without Commissioner Shannon being here, I can't speak for her. And I don't know the limitations of the grant. I wish I did. I do know that H Project Los Angeles was the grantor, and we should publicly thank them as well for giving us the money to have it hard copies printed, because there are people who want hard copies.
Thank you.
Okay.
Yes.
The executive summary and the conclusion, those two pieces, please. Okay.
Yes. So this was our introduction. I believe Claire wrote it. And it's an overview of, I believe, all 3 sections.
Okay. Just for the record, do you want to read that into, so for people who are not watching tonight?
Oh, yeah, absolutely.
They can hear it on
Yes.
public radio.
The Los Angeles City Health Commission is a government body established in 2014 by the Los Angeles City Council Ordinance Number 183093, with the mission to improve the health and wellness of citizens residing in Los Angeles City. The Health Commission is composed of volunteer commissioners and staff that focuses on understanding the health needs of people in Los Angeles City, conducting public health research, and providing information and recommendations that help Angelenos lead healthy lives. The Health Commission is requesting funding and resolution authority for 3 positions consisting of 1 executive director, 1 legislative analyst, and 1 commission executive assistant to allow the commission to fulfill its mission. The executive director position would require a master's degree in public health and some management experience. This position will be responsible for oversight of the commission and serve as a liaison with the Los Angeles County Departments of Public Health, Mental Health, and Health Services, as well as with the various city departments that provide health and safety services. This role is crucial to the developing partnerships and assisting in the coordination of the provision of services to the City of Los Angeles by identifying areas of need and recommended actions. This necessitates a high level of research, which would be the main role of the legislative analyst, a position that would require at least a Bachelor of Science degree in public health. This research is the basis for the development of this annual report, which articulates the areas of need and provides recommendations to address those needs. The Office of the City Clerk has provided the needed assistance in the conduct of Health Commission meetings. However, a dedicated Commission Executive Assistant would also provide support to the Executive Director and the Legislative Analyst, as well as to the Commissioners. The Health Commission is also requesting funds to support research programs to benefit the city's communities. We are requesting funding to conduct research studies focusing on the following: hospital bed shortages and access issues, especially for BIPOC communities, nursing shortages statewide, shortages of California licensed physicians due to technical maintenance of certifications, pharmaceutical and drug shortages, expanding access to healthcare for the homeless population, increases in infectious diseases, including respiratory illness and COVID-19 in Los Angeles schools, effectiveness of mobile healthcare units in meeting the needs of the homeless population and community outreach, and effectiveness of advanced practice nurses working with the Los Angeles Police Department and paramedics to address mental health issues with the homeless population.
I just noticed that the Los Angeles is not capitalized, so that needs to be corrected.
Corrected. The table below provides the requested positions and salary costs based on the level of knowledge, experience, and expertise needed and consistent with city position classifications and estimated office expenses and equipment costs. Any questions?
The other little modification I would say is where for the legislative analyst, the Bachelor's of Science, there are some schools that only give out Bachelor's of Arts, so I would just say a bachelor's level, just in case, because there are some, like Johns Hopkins University, you can get a Bachelor's of Arts in Public Health. They only give Bachelor's of Sciences out for nursing or engineering. We shouldn't limit some person who went to a very good school.
Okay,
Looks great, yeah.
thank you. Any other comments, questions, or concerns?
And then you just want to pop to the conclusions?
Yeah, sure. Should we go through the conclusions of each section or the
No,
conclusion
just
of?
the very end.
Okay,
The
yeah.
last,
Yes.
the bottom page.
Like page 83.
You could also type in 83 on the little,
74.
okay,
Now you're on 80.
there you go.
Right there, yeah.
More ahead.
Next page. There you go.
Yes, right there. The Los Angeles City Health Commission aims to provide policy recommendations in this report to address homelessness, healthy lifestyles, medical services, and COVID-19 surveillance and control in Los Angeles City. The recommendations are based on research, interviews, and presentations recently collected from experts and stakeholders in the Los Angeles community. The Health Commission encourages the City Council and public health community to adopt the recommendations contained within this report to improve the health of Los Angeles residents. The Health Commission also recommends that the City Council and Mayor implement the programs that are stipulated in the plan for a healthy Los Angeles. The Commission's work lies almost entirely on the dedicated work of volunteers. In order to produce high-quality research and effective recommendations for major public health concerns, the Health Commission requires financial support. A 2023 to 2024 budget allocation of $1,677,801 would provide adequate funding for full-time staff and directed research, which the Health Commission believes is necessary to accomplish its goals and objectives.
Wonderful.
Thank you.
Amazing.
So the motion's on the floor, and it's been seconded. Is there any discussion, debate, or other comments about the two parts that we read, as well as with the modifications of individual commissioners having the right to make sure that the verbiage of their own biographicals are accurate and up to date, and the most recent photograph is available with those three modifications. The third being the portion that Commissioner Cato upgraded and polished. If everybody's comfortable with that, is there any other discussion today before I ask for a vote? So what's on the floor is to approve everything that we just discussed and have it made available at least 72 hours prior to our next meeting for public comment and discussion, and then have ask for the vote to get it approved at the April meeting. Any other? Yes, please, Commissioner Coe.
Thank you. Could I ask a question not about the content, but about the, what happens after the commission publishes this annual report in terms of the city council? Because I see here it says that we are recommending that the city council and the mayor implements the programs that are stipulated in the plan for a healthy Los Angeles. So does that mean there's a follow-up from us to ask them?
So
follow
with all due respect, there's a motion on the floor that is asking for comment, and then we should vote on that, and then we can address your issue. So that's a little separate. So with that, can we have a roll call for the vote?
I'm sorry, who seconded the motion?
The city attorney said that we don't need to have a roll call on that. We just have to say all in favor of approving the motion. Aye.
Aye.
Any opposed or abstentions? Seeing none, it's unanimous. So we will then release it. Yes?
I'm sorry, the motion was Commissioner Chapa moved, and who seconded?
His,
Thank you.
Dr. Calfani seconded. To your point, so yes, Commissioner Ho, so we would send the report to the city council, to each city council office. We'd send it to the mayor, we'd send it to the city controller, and we'd send it to the city attorney, and obviously the city clerk. In addition, we have asked previously that a copy gets sent to the 5 supervisors and their health deputies, to the 15 health deputies for the city council members, and then all the state assembly members and state senators' offices that overlap the city of Los Angeles, the members of Congress that overlap the city, and the 2 U.S. senators. We send it. It doesn't necessarily mean that their health deputies read it and or review it, but we do send it and ask for their thing. In regards to the request for funding, we have already done that independent from the commission report. In our last commission report, we've requested monies, but we've also, I think, 2 separate funding cycles and 1 supplemental funding cycle, we've requested for similar funding. So the paperwork has already been done. I have already filled that out and have gone to the budget committee. I guess it's the budget.
A meeting with this, I think it was with the mayor and the city administrative officer?
Yes, to publicly represent you and to advocate for basically what's in that commission report. So we've done that 3 times separately, and there is a request to be included in the next budget, which we know for a fact that the chief administrative officer of the city and the budget individuals creating the city budget have already seen it and have seen the request. And there's documents filled out for that we can make available to you if you want to see what I filled out, but basically it's asking for that and giving backup and rationale for why.
So when you said 3 times, you mean 3 times for each previous budget year?
2 previous fiscal years and a supplemental. So there's a second chance to attempt to get funds added. So this last fall, there was a supplemental request that was sent. So it was two prior fiscal years.
Thank you.
Though I think, if I recall, and I could be off, I think in the last 3 reports, we've officially requested funding, but not with the data that we gave or the dollar amounts. It was more of a general request. In the last report, I think we just asked for $2 million without the backup but we did have requested staff as well as research monies in I believe the last 2 reports, if I recall properly. Amazing job, Monica.
Thank
Yes.
you so much. I just wanted to double check. You said that the 3 adjustments were 1, double checking headshots bios. The second one was making sure that the feedback from city planning was incorporated, and you said the third was from.
We just did it.
Okay. Okay.
Yeah. So
Okay.
that was just approving the conclusion and the introduction
Okay, amazing.
here, which we did with 3 minimal modifications: the LA capitalization in the baccalaureate. Yeah.
Okay, amazing. Thank you.
Those are the three. Wonderful. Excellent. Any other questions for Monica?
Thank you, guys.
So again, publicly, Monica, I want to thank you on behalf of the people of Los Angeles and the entire city for your efforts. And if Claire is watching this from Durham, and our other two graduate students who are in a PhD program in a medical school who are also helping us, we could not do these reports without your efforts. And you've really been the lead person this year coming. And I think publicly, on behalf of the entire people of the city of Los Angeles, we thank you, Monica.
Thank you guys so much.
Thank you.
Any new business?
I just thought I'd mention something that you may have seen in the news, that the LA Fire Department has asked them to discontinue a therapeutic van program that Department of Mental Health of the county was operating to respond to psychiatric emergencies. It turns out that the folks on the vans did not have any medical or paramedical qualifications, and most often the psych patients had some mental or substance abuse problem, so that they'd end up calling the fire department anyway, and the use was very, very low. Now that's distinct from the fire department's program that has nurse practitioners or physician assistants that can handle a wide range of issues. But I just thought it was interesting because that was one good idea that the fire department, and we'll see about the city council, thought was a good idea, but it doesn't turn out to have been very productive.
But my recollection is that was a pilot program of interest. It was $4 million. It wasn't like such a small pilot, but it was a pilot program.
Well, it has a few locations. They funded it for a few $1 million.
Correct. I think
But,
four. But the important thing about that is, I think what they learned from it was not to get rid of the program per se, but that they also need to have other professionals with other capabilities on it.
Yeah.
And we have had, and something we should look forward going forward, is to have the chief medical officer for the LA Fire Department come back to us again and present, because there was a discussion 2 years ago, I think it was, that there was a concern already back then that those individuals could only handle mental health and not
Right, they
medical.
couldn't handle that
And that
physical.
maybe it would be more efficient to have several people on the vans. Clearly that's the case, I think.
Anyway, it's gone to the Fire Commission. They sent it to the City Council. I haven't seen yet whether it's been agendized at the City Council. It went to the Fire Commission on March 5th, and I'm going to look and see, but whether there's further debate. It's a nice idea, but it didn't seem to work out as well as they thought.
Right, and I think that's one of the reasons we've asked for funding for research associates, because I do think that if we had full-time staff that could be researching some of this, that maybe we would have gotten there soon. We, the city of Los Angeles, would have gotten there sooner, and we could have given them input and helped the Fire Commission partner with them, so that having data, so it doesn't take 4 years to figure something out on a pilot program. Dr. Califani.
Yeah, just a quick thing, and I don't know if it's even appropriate, but it's something I've been thinking about. Some of you may have heard or are aware of the LA County staff person that committed suicide. So I was just wondering if we should even be thinking about, we talk a lot about health as it relates to consumers and residents. Should we also be thinking about employee safety and health as well? Just something to presentation or some conversation. I don't know, it's just something that I've been just thinking about a bit more as something to be thinking about.
It's part of our mission, according to
Yeah.
the ordinance. I think that part of that would be human resource issues. So I think that would be a great idea. We can look into that. Maybe our research associates could contact or work with the city clerk to see if there is a human resource department individual who's responsible for advising the head of HR on mental health issues for the employees of the city of Los Angeles. I think that'd be wonderful. Yeah, I think that's a great idea. Any other ideas? Or? No?
I would encourage if you can have someone from the city and the county, because the county also serves the city. And so if you can have both representatives, so that
In regards to that last topic, or just in
Yes.
general?
The last topic, just so that we're all covered with that conversation.
Yes, I think
Okay.
that's a good idea.
Thank you.
That'd be wonderful, sure. And then also, the mayor was in Paris discussing plans for the Olympics. And I think that's really interesting. We've talked about, both in our last report, in this report, and also here in City Hall, about healthcare planning and pandemic potential avoidance. Perhaps we should also, going forward, bring somebody from one of the schools of public health to discuss their idea and their thought process and what kind of plans could be done. So it's something else we should probably look into, I think. Professor Anne Ramoyne previously testified here about that. I'm going to say best estimate 8 months ago, if you remember, maybe 9 months ago, and she brought that up when she was talking about monkeypox. I could be off on the month; it might be longer than that, but I believe she was the last person to bring that up. So potentially she'd be the first person we should go to, being that she's already knowledgeable about how worldwide pandemics happen. She brought up a concern for that, and to see what inroads she's made, and if not, maybe we can help her work with the people from the city who are working on the Olympics to make sure that they're up to speed.
That makes sense, yeah.
Cool. Any other suggestions? If not, I'll ask for a motion for adjournment. So if the motion for adjournment was Hisarick and...
No, I was going to continue talking. I had something to ask.
Please.
Sorry. I believe, last month, a few of the commissioners had an opportunity to meet with the mayor's office. I wanted to follow up to see if that meeting had occurred and if there was anything of public interest that had come out of that meeting.
We did meet, and that was in regards to the budget and what we just talked about 10 minutes ago, 12 minutes ago. And so it's in the budget process. We testified, begged, requested funding for everything that's in the report, and supported with data for them, both ourselves as well as the city clerk. I believe also their office supported us as well.
Thank you for the
And
clarification.
we haven't heard back yet. It's in the process.
Understood.
Yeah, okay. Now, motion for adjournment. Hisarick with a second.
Second.
Second, Dr. Califani. All in favor? Anybody opposed or abstaining? No, we're
Adjourns. Thank you.